Assalamu alaikum. I hope that everybody is happy and enjoying these what we call as the virtual lectures from our home or and today's lecture is on valvular heart diseases. We have covered so far aortic valve disease and mitral valve disease. Though uncommon, but tricuspid and pulmonary valve disease is also uh, sometimes seen. Most of the time, it is secondary to either the left heart disease or maybe the lung disease, but it's equally important to recognize these features. And we'll be covering tricuspid stenosis and pulmonary tricuspid regurgitation. Similarly, pulmonary stenosis and pulmonary regurgitation, although less common. And then in the end, we'll be summarizing the two major valvular lesions, mainly aortic valve and the mitral valve, and we'll have a comparison of their symptomatology, their investigations, so that it is well understood by each and every student of us. So, talking of tricuspid stenosis. Now, if you look at these two diagrams, the one on the right hand of your panel shows a normal tricuspid valve opening, and you can see blood flowing normally from the right atrium to the right ventricle. And of course, during systole, it has to flow to the pulmonary artery. But if you look at the on the right side, the right side of your screen, you see a stenosed tricuspid valve. Now, this stenosed tricuspid valve would lead on to less blood flowing from the right atrium to the right ventricle. Of course, that would lead on to reduced cardiac output from the right side of the heart, less blood going to the lungs for oxygenation, and patient would feel some fatigue and other symptoms. The same would lead on to a back pressure effect in the right atrium, and this right atrial pressure then is transmitted uh, upward or backward. It would lead on to rise in jugular venous pressure, and when it is backward pressure into the inferior vena cava, and then into, of course, into the liver and hepatic veins. Liver becomes congested, it becomes pulsatile, and it becomes tender as well. So the symptoms because of the tricuspid stenosis would be because of its low forward flow to the right from the right ventricle to the lungs and back pressure. So fatigue, dyspnea, and exertion. Since the blood has to flow from the right atrium to the right ventricle during diastole, so a narrowing of at that level would produce a diastolic murmur. This diastolic murmur would be best heard along the lower left sternal border. It would be more prominent during inspiration and would have sometime maybe accompanied by systolic thrill as well. The back pressure effect would lead on to rise in jugular venous pressure. There would be hepatomegaly. Uh, Later on, it may also lead on to accumulation of fluid in the peritoneal cavity in the form of ascites. And this jugular venous distension with giant jugular A wave is a very prominent feature which is seen in the neck veins. This is a 2D echocardiogram representing the two arrows showing the rounded and thickened cusp of the tricuspid valve. Of course, you would see two cusps in this view only because the third, the one which is posterior cusp, is not visible. And this again, dilatation of the right atrium, and you may see there is some defect at the level of the foramen ovale, possibly because of increased right atrial pressure, may lead on to some blood flowing from, if there is a patent foramen ovale, from the right atrium to the left atrium. This is a Doppler representation of the flow across the tricuspid valve. So as you can see, the blood flow pattern or velocity are similar that are seen on the left side on the mitral valve. So there is a say reduced EF slope, and the A wave is prominent. So tricuspid usually occurs if it is associated with it because of rheumatic heart disease, with aortic and mitral stenosis. But the isolated involvement of the tricuspid valve in rheumatic heart disease is very, very rare. It's less than 5%. So reduced blood flow from the right atrium to the right ventricle, there would be reduced right ventricle output, reduced left ventricular filling because less blood going to the lung for oxygen. Of course, it would be less going to the left ventricle as well. So there's a decreased cardiac output overall, and back pressure would lead on to congestion, and forward decreased systemic pressure would also be one feature. The symptoms of right heart failure would be there. There would be hepatomegaly, liver would be enlarged, it would be tender, it would be pulsatile as well. There may be ascites, there will be edema, and there will be distension of the jugular venous veins. And of course, when the atria pushes too hard to overcome the obstruction caused by the tricuspid valve, it would lead on to very, very prominent A wave in the jugular venous pulse. The patient may also have fatigue and hypotension. As we said, when you look over the physical examination, the JVP would be raised, and there would be a mid-diastolic murmur best at the lower left or right sternal border, and it would be made more prominent during inspiration. The management of tricuspid stenosis would be either valve replacement, depending upon how much this valve area is reduced, how much the valve anatomy is disturbed, it is calcified, or it is repairable or not. If the valve is pliable, you can undertake valvotomy as in case of mitral stenosis, and balloon valvuloplasty is another option available for management. Tricuspid regurgitation is relatively more commonly seen. Why more commonly? It's mostly because of the pulmonary hypertension leading on to a back pressure effect onto the right ventricle, and this right ventricular back pressure then leads on to dilatation of the right ventricle. The cusps are pulled apart, and tricuspid valve become secondarily regurgitant. So tricuspid regurgitation can be seen in patient with mitral stenosis, which as a part of course of their disease develop pulmonary hypertension, and this pulmonary hypertension when transmitted would lead on to secondary tricuspid regurgitation. Tricuspid regurgitation can also be seen as a result of lung diseases or COPD, leading on to what we call as a cor pulmonale. Cor pulmonale mean cor is the heart disease, pulmonale which is second to the lung disease. So long-standing chronic cough, chronic bronchitis, or COPD would lead on to hypoxia, and this hypoxia then of course would lead on to reflux, pulmonary arterial vasoconstriction, and this pulmonary hypertension then would lead on to right ventricular hypertrophy, dilatation, and in the end it would lead on to tricuspid regurgitation. So it's more common than tricuspid stenosis. It is most frequently, as I said, is functional as a result of enlargement of the right ventricle. An insufficient tricuspid valve allows blood to flow back during systole from the right ventricle back to the right atrium. Instead of blood flowing towards pulmonary artery to the lungs, it flows back into the right atrium. And then there would be a volume overload state for the right atrium, and the back pressure would be transmitted to the jugular veins, and they would distend, and the same would be transmitted back to the liver and hepatic congestion and all the abnormalities as a result of congestion of the liver, and of course secondary ascites, and as we described for tricuspid stenosis, they would also be there. But here the main effect is the volume, whereas in tricuspid stenosis it was more as a pressure overload type of a situation. This is again a representation of tricuspid pathology, like on the left side in the larger cartoon or the diagram, what you say is that during systole, tricuspid valve is closed and blood is flowing from the right ventricle to the pulmonary artery. But if you see on the inbox on the upper right corner of your slide, during systole, blood is flowing, part of it flowing towards the pulmonary artery where it has to go, but majority of the blood is flowing back to the right atrium. The causes of tricuspid regurgitation, I said, rheumatic heart disease is, as if you can divide into primary causes or secondary causes. Primary means that the valve itself is defective. So rheumatic heart disease, as we have been repeatedly saying, is a less common cause of tricuspid valve pathology, because the order of involvement of various heart valves in rheumatic process is that the most common valve which is involved is mitral, and then aortic, and then possibly tricuspid, and very, very rarely the pulmonary. In fact, it can, you know, be involved in process of endocarditis. Again, endocarditis is more and more seen in patients like IV drug abusers, because in them they inject with the infected, say, syringes, or they share syringes from a patient, or they don't cleanse their arm before injecting, so they put in staphylococcal bacteremia is takes place, and the first valve which comes in this course is the tricuspid valve, which can involved in, so right-sided endocarditis uh, is probably the more common cause of tricuspid regurgitation, particularly in IV drug abusers. Abstain anomaly is another congenital anomaly of the tricuspid valve. In this condition, the tricuspid valve is set very low towards the right ventricle. So they have a very huge, large right atrium, low set tricuspid valve, particularly the septal leaflet of the tricuspid valve, leading on to very small right ventricle and a very large giant type of an right atrium. And of course, this pathology is associated with tricuspid regurgitation, as well as sometimes coexisting atrial septal defect. Another disease which can involve the right side of the heart and particularly the tricuspid valve is the carcinoid disease. Again, the carcinoid is you have 5-hydroxyserotonin or 5-hydroxytryptamine being released, and this substance normally, if it metastasizes the liver, and then it can go on to the right side of the heart and can lead on to tricuspid valve pathology. But more likely, you have secondary causes of tricuspid regurgitation, and as we have shown in very bold letters, pulmonary hypertension or cor pulmonale, or pulmonary hypertension secondary to lung diseases, or COPD. This is a more common cause. Right ventricular dilatation due to chronic left heart failure, like functional tricuspid regurgitation, as we described in patient with mitral stenosis, and sometimes an acute right ventricular infarct can lead on to, say, rupture of the muscles, or rupture of the fibers to the various leaflets of the tricuspid valve, and can be a reason for secondary tricuspid regurgitation. Symptoms are usually non-specific. Again, depends upon if it is because of the lung disease. Those predominant symptoms would be because of the lung disease, like cough and cyanosis and dyspnea or breathlessness or wheezing. And then, of course, when the right heart failure add on, they would complain of tiredness, fatigue because of reduced flow. Edema is universally there, and hepatic enlargement and venous congestion is there. JVP would be raised, and the auscultatory finding in tricuspid regurgitation would be a pan-systolic murmur, which is best, it's a harsh murmur, which is best heard at the lower left sternal border. It would have an inspiratory exaggeration. It would be more loud during inspiration. And if you trace its radiation, you can radiate this murmur towards the epigastrium mainly. And of course, in a tricuspid regurgitation, you would also have a liver which is enlarged and is pulsatile. The management would be treating the underlying cause, correction of that cause which is causing right ventricular dilatation, overload, or failure. So treating the lung disease and reducing their hypoxia, which would, of course, then lead on to reduction in pulmonary arterial pressure, would be one thing which can be done. If it is secondary to pulmonary, say, mitral stenosis, then that mitral stenosis needs to be dealt with as required, maybe replaced or maybe repaired, or may go balloon valvuloplasty. For medical management, of course, since there's an quite overloaded condition, there is a congestion of the liver, there is edema, so diuretics and some vasodilators may be of benefit, and they are used in treatment. But definitely, the definite treatment would be either you repair this valve or you replace this valve. As we already mentioned in the beginning, that pulmonary stenosis is less commonly seen, and if it is seen, it usually is usually because of the underlying congenital conditions. So the symptoms of pulmonary stenosis would be fatigue, dyspnea, and exertion, because less of the blood would be going to the lungs for oxygenation, and the patient may also complain of cyanosis. Since it's more commonly seen since early childhood birth, there would be poor weight gain, there may be failure to thrive in the infants, and again, the pulmonary stenosis would put its pressure onto the right ventricle would hypertrophy and then dilate, and then, of course, all the back pressure mechanism or say a manifestation in the form of ascites and edema would occur. Signs would be that there would be an ejection systolic type of murmur, which is loud at the left upper sternal border or which radiates towards the clavicle or to the left shoulder. Murmur is often preceded by an ejection sound or ejection click, as is seen in aortic stenosis on the left side. There may be wide splitting of the second heart sound, because a stenosed pulmonary valve would lead on to delayed in the closure of the pulmonary valve. So because of the disparity in the closure of the aortic or pulmonary valve, aortic valve will close earlier and pulmonary valve will close late. This would lead on to say a time interval between the two components of the second sound, which is called as splitting, and this would be wide splitting, but it still would maintain its variation with the respiration. A palpable thrill in the second left intercostal space or towards the left of the sternum in the upper part may be there in patient with the pulmonary stenosis. ECG would show right ventricular hypertrophy, understandably so. The chest X-ray would show a post-stenotic dilation in the pulmonary artery, which would be because of a high pressure jet from the pulmonary valve going to the pulmonary route and leading its main pulmonary artery being dilated. Definitive diagnosis would be made through a Doppler echocardiography, or that is the maybe investigation of choice. The management of a pulmonary stenosis, a mild to moderate isolated pulmonary stenosis, is relatively common and does not require any treatment. It is usually benign in course and usually does not progress. But severe pulmonary stenosis, of course, would require a percutaneous pulmonary balloon valvuloplasty or maybe surgical valvotomy. Pulmonary regurgitation is again, as I said, mostly because of secondary to lung disease or secondary to mitral valve disease. And this again can be classified as isolated pulmonary regurgitation per se is rare. It is usually associated with pulmonary hypertension, which may be, as I said, secondary to the disease of the left side of the heart, like mitral stenosis. It may be some primary pulmonary vascular disease, and occasionally it can be because of the Eisenmenger syndrome, in which it means that an initial left to right shunt after development of pulmonary hypertension becomes a right to left shunt leading on to cyanosis. Blood flows back into the right ventricle during systole, and the right ventricle and atrium would hypertrophy, and there would be symptoms of right heart failure. Now, trivial PR is or pulmonary regurgitation is a frequent finding in normal individuals and has no clinical significance. Uh, the physical finding in pulmonary regurgitation would be that P2 or component of the second heart sound would be palpable. There would be an evidence of right ventricular hypertrophy, which you see by placing your hand to the left of the sternum and looking for a right its elevation with each heartbeat. JVP would be raised. Now, when this pulmonary regurgitation is as a result of secondary to the mitral valve disease or mitral stenosis, it would be leading on to a early diastolic murmur at the base of the heart, and this murmur is called as a Graham steel murmur. Though P2 would be loud, and as I said, early diastolic murmur at second left ventricular space would be a more characteristic feature of pulmonary regurgitation. Treatment of pulmonary regurgitation would be treating the underlying cause. If it is secondary to mitral stenosis, treat that. If it is secondary to the lung disease, treat that. And if it is part of, say, more complex congenital conditions, you have to treat that condition or correct that condition. This ends are valvular pathologies. Some of them, as we said, are because of rheumatic heart disease. Some of them are because of degeneration. Some of them are because of some abnormality in the vasculature or the disease of the aortic root. So, since the two more common lesions are involvement of the mitral valve, either stenotic or regurgitant, or involvement of the aortic valve, either regurgitant or stenotic. We'll have a comparison of each one of them, and we'll talk about compare their symptom, their etiology, and ECG finding, so that it is easier to remember what to uh, expect in each one of them. So this is a table showing summary of severe valvular heart diseases. As I said, the more common lesions are aortic stenosis, mitral stenosis, and mitral regurgitation and aortic regurgitation. As far as etiology goes, the aortic stenosis, as I said, is more commonly idiopathic calcification of bicuspid or tricuspid valve, or maybe congenital, and sometimes it is rheumatic. Etiology of mitral stenosis more commonly is because of rheumatic endocarditis following a sequence of rheumatic fever, and there can be calcification of the annulus of the mitral valve, and this annular calcification is more common reason for stenosis in relatively older age or relatively middle-aged person. Mitral regurgitation, the more common cause is mitral valve prolapse. It may be because of rupture of chordae tendineae in process of myocardial infarction or endocarditis, or as I said, ischemic papillary muscle dysfunction or rupture. Sometimes it can be part of collagen vascular disease and syndromes, and again it can be as a result of secondary to left ventricular myocardial disease leading on to, like in cardiomyopathies, the dilated left ventricle pulls apart the cusps and leads on to mitral regurgitation. Aortic regurgitation is as a result of annulo-aortic ectasia or root being malfunctioning or dilated, pulling apart the cusp. Hypertension, endocarditis, Marfan syndrome, ankylosing spondylitis, aortic dissection, syphilis, and collagen vascular disease are other causes of aortic regurgitation. The pathophysiology in each of the lesion, like in aortic stenosis, there is a condition of a pressure overload situation onto the left ventricle. And of course, the valve is stenotic, left ventricle tries to compensate, it hypertrophies and finally dilates, and then it starts failing. This again also puts during diastole there is less blood flow flowing to the coronaries, and this coronary blood flow reserve is reduced, and the patient may become symptomatic because of the reduced coronary supply as well. In mitral stenosis, the obstruction to the left ventricular inflow during diastole from left atrium to the left ventricle puts a pressure onto the left atrium first. There is less blood flowing to the left ventricle, so cardiac output understandably is reduced, and the mitral valve obstruction increases pressure, back pressure into the pulmonary venous circulation, then leads on to pulmonary arterial vasoconstriction, and this pressure is then transmitted to the right ventricle, and it is right ventricle which fails secondary to left atrial pressure being increased on mitral stenosis, and left ventricle per se in the mitral valve mitral stenosis is not at least uh, receive any burden. So right ventricular pressure overload is augmented further when pulmonary hypertension develops. When you talk of mitral regurgitation, it places volume overload on the left ventricle. Why? That during, say, diastole, there is blood flowing to the from the left atrium to the left ventricle, and most of it is regurgitated back to the left atrium again during systole, and instead of going, so with each systole, the left ventricle has to accommodate double the volume of blood, the one which has been regurgitated back and the one which has been received from the lungs after oxygenation. So this volume overload situation is compensated by progressive dilatation of the left ventricle. So eventually the left ventricle dysfunction develops, and this volume overload situation would lead on to left ventricular failure. As far as the aortic regurgitation, again, we talked about that the aortic regurgitation can be either chronic or acute. A chronic aortic regurgitation, the stroke volume causes hyperdynamic circulation. This leads on to systolic hypertension and causes pressure and volume overload. Both pressure as well as volume is increased, and this compensated by concentric and eccentric left ventricular hypertrophy. Whereas in acute aortic regurgitation, there is not enough time for the cardiac dilatation to develop. All the pressure from because of aortic regurgitation, which is put onto the left ventricle, and left ventricle not being able to dilate, transmitted back to the left atrium, and this patient suddenly or acutely goes into pulmonary edema or acute breathlessness dyspnea. The symptoms in patient of aortic stenosis, as I said, the cardinal symptoms are angina, syncope, and heart failure. The symptoms in mitral stenosis are dyspnea, orthopnea, paroxysmal ductal dyspnea. Sometimes they may have hemoptysis as a result of pulmonary venous congestion and some of the venous pulmonary veins being eroded and become leaky. There may be hoarseness of voice as a result of left atrial enlargement, which presses upon to the left recurrent nerve. And when this right heart failure sets in, there would be edema and sometimes ascites as well. Mitral regurgitation primarily presents at dyspnea, orthopnea, and paroxysmal ductal dyspnea. Aortic regurgitation again does dyspnea, orthopnea, paroxysmal dyspnea, sometimes angina and syncope, all may be seen in aortic regurgitation. The signs in aortic stenosis are systolic ejection murmur, which radiates to the neck. There will be delayed carotid upstroke. There may be S4 or fourth heart sound or additional diastolic sound because the left ventricular hypertrophy does not let the left ventricle to dilate during late atrial contraction. And of course, there would be paradoxical S2 splitting. The symptoms, the signs in mitral stenosis are usually a diastolic rumbling, flowing murmur, and an opening snap, which is best heard at the apex in the left lateral position and then louder in expiration. First sound would be loud. There would be an evidence of, depending upon duration and severity, the right ventricular hypertrophy, and P2 would be loud when pulmonary hypertension develops. The mitral stenosis is a classical mitral regurgitation. Sorry, the mitral regurgitation classically presents with a pan-systolic or long systolic or hollow systolic murmur, which is best heard at the apex. This murmur is louder during expiration, and if you trace its radiation, it radiates towards the axilla, and of course there would be displacement of the apex beat or point of maximal impulse for the heart. Again, aortic regurgitation. Chronic aortic regurgitation would be associated with a diastolic blowing murmur, best heard in the second left intercostal space in sitting position. The circulation would be hyperdynamic. There were quite a few signs like Quincke sign, de Mose sign, and so many other signs which were described. Apex beat, of course, would displace as a result of dilatation and hypertrophy of the left ventricle. But in acute aortic regurgitation, there may be a short diastolic blowing murmur, and there would not be much an evidence of dilatation of the heart. ECG finding in aortic stenosis predominantly will be left ventricular hypertrophy and then secondary left atrial hypertrophy. In mitral stenosis, it would be a left atrial enlargement as well as right ventricular hypertrophy. In mitral regurgitation, again, there would be left ventricular hypertrophy and left atrial enlargement, whereas in aortic regurgitation, of course, left ventricular hypertrophy and left atrial enlargement would be there. In chest radiograph, the aortic stenosis heart, because of its left ventricular hypertrophy and rounded shape, classical boot-shaped heart would be seen in aortic stenosis. You may also observe aortic valve calcification in a lateral view in a long degenerative aortic valve which is stenosed. Then in mitral stenosis, you may have double density at the right heart border because of the left atrial enlargement, which produces a double atrial shadow. You have curly B lines in the on the X-ray, which are because of the dilatation of the lymphatics, the fluid which is transudated out into the intestinal space is then carried on by the taken away by the this lymphatics, and this lymphatic would lead on to prominent shadows or lines mainly seen in the both angles of the say costophrenic angles areas. Pulmonary artery enlargement and of course straightening of the left border of heart are other features which were discussed and shown in previous lectures. In mitral regurgitation, there would be overall cardiac enlargement and congestion. In aortic regurgitation, of course, you would have cardiomegaly and some uncoiling of aorta. In chronic cases, but in acute cases, there would be pulmonary congestion with heart size may be normal. Again, we have seen this in a previous lecture on aortic valve disease. In echocardiographic findings, there would be concentric left ventricular hypertrophy in aortic stenosis. There will be reduced, excuse me. So there will be reduced aortic valve cusp separation. Doppler will show a mean gradient of more than 50 million mercury in the most severe cases. The normal gradient across the aortic valve is usually 10 to 15 mm of mercury. In mitral stenosis, you would see restricted mitral leaflet movement. There would be doming of the leaflets as a result of increased left atrial pressure. You may see calcification. You can measure the area both by 2D Doppler by planimetry, or you can measure it indirectly through the this Doppler or by what we call a pressure half-time technique, which measures the velocity across the mitral valve, and then you can calculate the area through that. Similarly, this mitral stenosis, as we said, would lead on to back pressure onto the right ventricle, and there may be tricuspid regurgitation as well. And this presence of tricuspid regurgitation, pulmonary hypertension actually are signs of a severity of mitral valve disease. In mitral regurgitation, the left ventricle and the left atrial enlargement in chronic severe cases, and of course, then on Doppler, you would be seeing a large jet flowing back from the left ventricle to the left atrium. Aortic regurgitation in chronic cases, there would be left ventricular enlargement, and there would be a large Doppler jet flowing from aorta back into the left ventricle during diastole. And of course, this pressure after time of less than 400 is an indication, is a sign of a severity of the mitral aortic regurgitation. In acute, of course, there is not time enough to left ventricle to enlarge, so the LV may not be that enlarged, but the mitral valve pre-closure or that can be seen. On catheterization, in aortic stenosis, there is increased left ventricular and diastolic pressure. The transaortic gradient of more than 50 millimeters is sign of severity. In mitral stenosis, there is elevated pulmonary capillary wedge pressure and transmitral gradient, the pressure difference between the mitral left atrium and the left ventricle during diastole, if it is more than 10 millimeter of mercury, is sign of severity. In mitral regurgitation, there is ventriculography would show the regurgitation of dye into the left ventricle, and in aortic regurgitation on catheterization, there would be wide pulse pressure noted, recorded, and aortography would show regurgitation of dye into the left ventricle. Again, the severity of aortic stenosis is when it is the area is less than 0.7 centimeters square, it is considered as severe aortic stenosis. Mitral area of less than 1 centimeter square is a sign of severity. And again, aortic regurgitation, as we said, is severity is judged through the pressure half time on this Doppler, and then the aortography showing the regurgitation jet into the left ventricle during diastole. Medical treatment for aortic stenosis is that you don't give vasodilators, digitalis, diuretics, and nitroglycerin in inoperable cases. You initially use diuretic for milder mitral stenosis and when there are minimal symptoms. When they develop atrial fibrillation during course of their illness and because of enlargement of left atrium, anticoagulation becomes necessary to be given. Digoxin in those who are fibrillating, beta blockers to slow the heart rate, verapamil, diltiazem for rate control, they are used as a part of treatment. Again, mitral regurgitation is a volume overload condition, so the mainstay of treatment would be diuretics, and when they become symptomatic, vasodilator may also be used. Again, vasodilators and diuretics are usually initial mode of therapy in aortic regurgitation. Indications for surgery in aortic stenosis is if a patient is symptomatic with severe disease. Again, we talked about some echo, say, indicators that if you have a dilated valve area of less than 0.7 or a pressure gradient of more than 50 millimeter of mercury across the aortic valve, it becomes an indication for some surgical intervention. In mitral stenosis, again, when symptoms are more severe, when they develop pulmonary hypertension, and of course, when there is an atrial fibrillation developing, it means that the disease is severe and would need surgical intervention in the form of either replacement or repair or maybe balloon valvuloplasty. Mitral regurgitation when the ejection fraction is less than 60% or and systolic diameter of more than 45 millimeter echo is an indication for valve repair surgery. Aortic regurgitation again, an ejection fraction less than 55 and systolic diameter more than 55 in patient with chronic, but in acute, even mild heart failure or a mitral valve pre-closure would be an indication for surgical intervention. Thank you very much. We have covered all the valvular pathologies. Some of them are more important, like each and every one should be very much familiar with the mitral stenosis and its consequences. It's a very commonly short case in say exam. Similarly, the involvement of aortic valve and aortic stenosis and more commonly aortic regurgitation are again a very common short case in the examination, and you should be very much familiar with all the peripheral signs which we described for aortic regurgitation, and you should be able to answer that when we call a valve to be significantly stenosed and when there is an indication for surgical intervention or a referral to the competent cardiac service. Thank you.